Hey everyone, welcome to Dump the Charge and part 2 of the shock videos. In this video we're going to go through the stages of shock, how a patient may present when they're in these stages, and how to go about managing these patients. If you haven't already, I would recommend watching part 1 of this video. It's the same video that I've just split in two. I do touch on a few things in this video that sort of relate back to that one. But if you have already and you're ready to rock and roll, let's get to it. Great. Now that we've gone through all the different types of shock, let's get a bit more stuck into the meat and potatoes of what happens when shock kicks in. So what we're going to see is we're going to see a progression of symptoms along a spectrum as a patient deteriorates. This spectrum moves through 3 defined stages of shock, each one worse than the last. Now, while it's safe to say that most people that experience shock will go through each one of these stages, it's really important to identify that depending on the patient's age, their frailty status, past medical history, medications, the type of injury they're experiencing, they may actually start at a more progressed stage of shock, or they may progress very quickly through all of the stages of shock. It is so important to identify exactly what stage the patient is in order for us to determine just how quickly they're going to deteriorate and how big the risk of death or severe morbidity will be. Now, as we work through all of these stages, let's consider the following scenario. So we're dispatched to 2 patients. Let's call them Elaine and Joseph. Elaine is a young, fit and healthy 30-year-old female with no past medical history. Joseph is her not so young, fit and healthy father. We'll say he's 65 years old, and he does have some significant medical history. Elaine and Joseph were walking along a country road this afternoon when a car who was traveling at some speed, let's say 80 kilometers per hour, has lost control, come off the side of the road, and has impacted with them. We'll say by the time the scene was approached by bystanders, an ambulance was called, the ambulance was dispatched, and considering our travel time to the job, 35 minutes has passed since the time of the incident. We find Elaine to be conscious and breathing. She's a heart rate of 130, blood pressure of 110 on 70. She's cool, pale, and clammy. She has a rest rate of 28 with clear air entry bilaterally to bases. A thorough secondary survey finds multiple injuries, but most significantly, we find a partially amputated right leg above the knee, which was hemorrhaging uncontrollably. We have controlled that hemorrhage with a tourniquet. We've also found a fractured pelvis, which could be a source of a catastrophic internal bleed. We find Joseph to be in an altered conscious state, responding only to firm verbal stimulus. He has a heart rate of 145 beats per minute. He has a blood pressure of 95 on 45. He too is cool, pale, and clammy. He has a rest rate of 32, equal air entry bilaterally to bases. A secondary survey finds a obvious fractured pelvis, which we have bound with a pelvic splint, distension of the lower abdomen, which we are concerned may be internal bleeding. We also find obvious fractures of both of his femurs, which are themselves potential sources of internal hemorrhage. Joseph has had a heart attack about a year ago, which has resulted in a stent. He also has early stage cardiomyopathy, which is resulting in heart failure. Joseph is medicated for hypertension and hypercholesterolemia. Okay, so there's a lot going on with this job, but with this video, we're going to focus on the shock process. Both of these patients have received injuries that have caused both external and internal catastrophic hemorrhage. So what we are dealing with here is absolute shock from a hemorrhagic hypovolemia. All right, let's do it. Let's go to the board. Okay, so this is where we're going to rely pretty heavily on those hemodynamics formulas. So I urge you again to go and have a look at those if you haven't already. Let's start with cardiac output equals heart rate times stroke volume. And we should already know that 3 things that affect stroke volume quite significantly are preload, contractility, and afterload. Cardiac output is then taken and compared with peripheral vascular resistance to give us blood pressure, which is the driving force behind perfusion. For the most part, shock processes involve volume depletion. And in this particular case with our scenarios, we have an absolute fluid loss. So when there's volume depletion, we have less blood returning to our heart and filling our ventricles, which means it's a reduction in preload. Reducing preload will then reduce the stretch that the myocardium undergoes when it fills up, which would then reduce contractility. A reduction in these things will reduce stroke volume, which is the amount of blood that is expelled by the heart in a single beat. Now I do want to touch on something else here. A reduction in blood volume will also reduce afterload. And we know a reduction in afterload would mean that there's an increase in stroke volume. Now, while this is true, the effects of a reduction in preload and contractility far outweigh any benefit that we get from that reduction in afterload. So we'll have a net reduction in stroke volume. This reduction in stroke volume means that over the span of a minute, we have a reduction in cardiac output. And if we take that further, a reduction in cardiac output means that we have a reduction in blood pressure. This is where the stages of shock start. So the first stage of shock is called compensation. Now remember that the body likes homeostasis, right? It likes things just so, and it has to be that way all the time. If things get out of whack, it has a ton of contingencies and plans in place to bring everything back to normal, or as close to normal as possible. This is what happens here. So I want to start off by talking about baroreceptors.
What are these guys? These guys are kind of like quality control. They hang out in the aortic arch. Just as blood is pumped into the aorta, it passes these baroreceptors. At that site, they basically measure the pressure at which blood is leaving the heart, basically trying to work out whether the heart is doing its job well enough. Another spot that they like to hang out is in the carotid bodies. Blood has to go through the carotid bodies to enter the brain, so it's really important to measure the amount of pressure there is in those blood vessels in order to make sure that there's adequate pressure to push blood up to the brain. If they find that the pressure is too low, they don't mind telling someone. They go up to the boss, which is the brain, and they tell them that things aren't being done right. The brain will then implement a ton of changes to improve efficiency. So in terms of the shock patient, the baroreceptors in the aortic arch and the carotid bodies detect that there is a sudden drop in blood pressure because we've had this drop in cardiac output. They send a signal to the brain, who will then initiate the sympathetic nervous system. Why does this help? So the sympathetic nervous system will operate via activating beta-1 receptors. Now, beta-1 receptors do a few different things at the heart. Primarily though, for our purposes here, it will stimulate an increase in heart rate. Raising heart rate will then compensate, see how the words match? Will compensate for this reduction in stroke volume that we're experiencing. So let's break that down and put some numbers to this just to demonstrate it for you. So let's consider a normal heart rate. A normal heart rate sort of sits between 60 and 100 beats per minute. So let's say 70 beats per minute. Considering stroke volume tends to be about the 50 to 100 mil per beat mark. So let's say 75 mil. If we multiply them together, we get 5,250 mil per minute. That's a normal cardiac output. That's what my brain likes. That's what my body likes. Any huge alteration in that number is bad news for the body. Okay, so let's say I've lost some blood volume now, and because of this my stroke volume is reduced to about 40 mil per beat. If I multiply 40 mil per beat by 70 beats per minute, I get 2,800 mil per minute. This is a huge reduction in cardiac output, and it's not something that the body can sustain. So it wants to do whatever it can to raise it back up to about the 5,250 mil per minute mark. So what can it do? It can't do anything about the amount of blood actually returning to my heart. But what it can do is it can increase my heart rate through the sympathetic nervous system. Now, in order to get anywhere near my old cardiac output, I'd have to increase my heart rate to 130 beats per minute just to get to 5,200 mil per minute, which is close enough. Now that's a pretty significant increase in heart rate just to maintain normal cardiac output and normal blood pressure. And spoiler alert, there will be repercussions to this. Now, innervation of the beta-1 receptors at the myocardium will also increase contractility. Now, normally this will increase stroke volume as well. The problem is that our issue is with volume depletion. So even with squeezing the heart harder, we simply don't have enough blood volume circulating to increase stroke volume adequately. So the effects of this are negligible. Another important job of the sympathetic nervous system in these patients is the activation of alpha receptors that sit at our peripheral blood vessels. Now, activation of the alpha receptors causes a contraction of vascular smooth muscle in our peripheral vascular system, causing vasoconstriction. Vasoconstriction will increase peripheral vascular resistance, and hopefully that way, when compared to cardiac output, increase our blood pressure. Another benefit of this is that by squeezing all of the blood vessels in our peripheries, we're pushing more blood towards our core and towards our heart. This will increase venous return and preload. Increasing preload will then increase stroke volume and hopefully cardiac output and blood pressure. This venous return effect has varied benefit depending on the type of shock that we're facing. If we have someone that's in distributive shock from their blood vessels expanding too much, causing a vasoconstriction is going to help with that quite well. However, if we have someone that is experiencing actual blood loss out of their body, squeezing those blood vessels is going to do very little to help them without adequate fluid replacement first. So we call all of these effects compensatory effects because they're trying to compensate for a reduction in stroke volume and a reduction in blood pressure. All right, let's go back to our scenario and have a look at our patients. Now, Elaine certainly has injuries that indicates that she's lost a significant volume of blood. Looking at her rolls, we find that she's actually normotensive, but she has extremely high heart rate, 130. This should immediately raise alarm bells, being one of the first signs of compensatory shock. On top of the tachycardia, we find that Elaine's skin is pale and clammy and cool to touch. So what's this telling us? To find the significance of this, let's talk about what gives our skin its hue and its temperature. The depth of skin tone that a healthy person has is related to the color that red blood cells give blood. When that blood is closer to the surface of the skin, that hue comes through and we get that sort of deep color that healthy people present with. Similarly with heat. Heat is carried in our blood. When blood is closer to the surface of the skin, we can actually feel that warmth come through our skin. As soon as blood is taken away from a site, that site becomes cool to touch. So thinking about that, we can extrapolate that Elaine is moving blood away from her skin. This shunting of blood, particularly if it's widespread throughout the body, is indicative of systemic peripheral vasoconstriction. The squeezing of all those blood vessels will increase peripheral vascular resistance and also shunt blood away from our extremities into our core and increase stroke volume. So this is another clue that Elaine is most likely in a compensatory shock. A further clue is that Elaine is clammy. The body's sweat response is mediated by the sympathetic nervous system. So if the sympathetic nervous system is activated and in overdrive, as is what happens with a compensatory shock, we tend to become sweaty or at least clammy. Now finally, Elaine is tachypnic or breathing very quickly, but there are no adventitious breath sounds. There's no wheezing to indicate a bronchospasm. There's no fine or coarse crackles to indicate that there's fluid or mucus in the airways. There's no stride or snore to indicate that there's an obstruction of the upper airway. So for all intents and purposes, her lungs are completely fine. So why is she breathing quickly? This could be for two reasons. The first reason is that she's experiencing a sympathetic response, which will increase resp rate and resp depth. The second thing though is that most likely she's undergoing some form of acidosis, and the body tends to have this response to blow off carbon dioxide to reduce the amount of acidity in our body. We are going to touch on acidosis a little bit later in this video. Now, I am very concerned about Elaine. She needs immediate intervention, but I'm extremely concerned about Joseph. His obs are a little bit different if you go back and look at them. Let's move on to the next stage of shock, and we'll investigate why. Okay, so let's say that a second crew arrived around the same time that we did to that job. And we split up and we took over care of Elaine and the second crew took over care of Joseph. Both crews have performed all the appropriate management, packaged our patients and loaded our patients to our respective ambulances. Let's say we were pretty quick and we managed to do all of our interventions and safely extricate Elaine into our ambulance within 15 minutes. And let's say it's 40 minutes to the nearest hospital. Now, about 15 minutes into our trip, we notice that Elaine's obs start to change a little bit. We find that her heart rate has climbed to 145 beats per minute. Her blood pressure is now 80 on 45. Her resp rate is 36 and she's now in an altered conscious state. So what's going on here? Well, if no interventions are taken to help a shock patient, or the interventions that have been taken just aren't enough to actually help, the patient will eventually deteriorate into a decompensated shock. As blood volume continues to reduce, so too does preload and contractility. This means that there is continuous progressive reduction in stroke volume over time. The body will valiantly continue its efforts to try to counteract this by increasing heart rate and continuing to hold on to that peripheral vascular resistance. However, as time goes on, a couple of things start to happen that will start to dismantle these mechanisms. Firstly, let's discuss the depletion of ATP. It's all well and good to say that the body will continue to hold its peripheral vasoconstriction on and on and on into the future. But we need to understand that in order to constrict a blood vessel, the body needs to constrict smooth muscle that is lining that blood vessel. Sometimes this contraction of muscle needs to be maintained for hours and hours on end. In order to maintain that constriction, we need to provide a continuous supply of oxygen and glucose so that it can produce a continuous supply of ATP in order to fuel that increased demand. But now we have a situation where we have actually reduced our perfusion. Blood isn't quite reaching as far as it used to. So if there's this reduction in supply of oxygen and glucose to an area where there's an increased demand for ATP, we're going to have failure of those mechanisms and we will vasodilate. This mismatch of supply and demand, particularly when metabolic demand is going up and supply is going down, we end up with more and more areas of our body becoming oxygen starved. Now remember that anaerobic respiration is an option for our body, but when it does that, it produces lactic acid. The more muscles in our body and the more organs in our body that are relying on anaerobic respiration, the more lactic acid is produced. The more lactic acid there is, the more acidic our blood becomes, leading to the development of a metabolic acidosis. Now, one of the many problems that arise from a metabolic acidosis is that acidosis promotes widespread vasodilation and an increase in capillary permeability. This is bad. Through both of these mechanisms, the depletion of ATP and the acidosis, we end up with a widespread vasodilation, which negates that compensatory increase in peripheral vascular resistance. At the same time, the acidosis causing fluid shifts causes a further reduction in blood volume, which will then compound on the already reduced preload and contractility, further reducing stroke volume, cardiac output, and blood pressure. The heart is going to continue to do its absolute best to beat as fast as it can to counteract all this. But that continuous reduction in stroke volume and peripheral vascular resistance will mean that we have a reduction in blood pressure despite all of the best efforts that the heart is putting in. So what are we going to see with this? Well, let's go back to Elaine for a second. She's still tachycardic. In fact, she's more tachycardic than she was earlier. This may be an indication to us that her body's working harder to maintain adequate perfusion. But what's more telling is that her blood pressure has dropped drastically. It's dropped from 110 to 80 systolic. This is clear evidence of a compromised cardiac output. She's still tachypnic, most likely due to the acidosis, but it is extremely important to reassess her chest to ensure that she hasn't developed any bronchospasm, fluid in her chest, or a pneumothorax. Let's say for the simplicity of the scenario that she hasn't developed any of those things. Finally, her conscious state is now altered. There could be a couple of reasons for this. One of them is that the reduction in cardiac output and blood pressure means that her brain is now more poorly perfused than it was earlier, which would mean that cognition becomes difficult and will lead to a altered conscious state. However, altered mentation is another little gift that old mate acidosis leaves behind for its victims. Either way, all signs are starting to point to decompensated shock. So to review, a patient with compensating shock will present with a tachycardia and pallor, but normotensive. As we progress to decompensation, we'll continue to see tachycardia and pallor, but we'll see blood pressure start to fall drastically, and perhaps we'll start seeing an altered mentation as well. Hang on. Let's think back for a second. What were Joseph's obs doing initially? Joseph was tachycardic at 145 beats per minute, and we found him to be hypotensive at 95 on 45. He was in an altered conscious state, and he was tachypnic at 32. Is this all starting to sound familiar? It sounds like Joseph was in a decompensated shock when we got to him, but he sustained his injuries at the same time that Elaine did. So why was he so much more progressed than she was? I cannot stress how important this point is. While the stages of shock tend to progress along a spectrum, there is absolutely no rule as to how long a patient must spend in each stage of shock, nor is there a rule that a patient must begin their journey in a compensated phase. Just remember that whatever stage they start in, they're going to get worse, not better. So why? What makes Joseph go through these stages more quickly? Well, let's look at his past medical history. Joseph has had a heart attack that has required a stent. It's conceivable, or even likely, that Joseph has sustained some kind of myocardial infarction in that heart attack. If his myocardium is damaged, it may be compromised to the point where it can't contract with as much force as it used to. Or there might be an issue with it being able to stretch enough to initiate the Frank-Starling law. While this may not affect him under normal circumstances and he can live life fairly normally, in a circumstance where his heart is put through the ringer, like we have in shock, it may not be able to stand up to the challenge. This reduction in contractility may be enough to mean that Joseph just simply can't compensate as efficiently as someone who hasn't had that heart attack, which means he will progress into that decompensated phase quicker. We also know that Joseph has cardiomyopathy and heart failure. Heart failure, if I put it very simply, is a compromise in the ability for the heart to pump efficiently. If he has a compromised stroke volume under normal circumstances, he's almost certainly going to progress into a decompensated phase much quicker when he is shocked. Finally, if we look at his medications, we see that Joseph is on antihypertensives and a hypercholesterolemia medication. Both of these indicate poor heart health, as we've already discovered through the rest of his past history. But the fact that he's on an antihypertensive means that he's on a medication that is actively trying to reduce blood pressure. Now, in a shocked state, the body is trying to increase blood pressure, and these two things may counter each other. Maybe he didn't even have a compensated phase. Maybe he went directly into a decompensated phase. Now, this is by no means an exhaustive list. There are so many factors that will play a role in this, far too many for me to list here. For example, someone with chronic obstructive pulmonary disease, they live their lives with a significantly reduced oxygen saturation. So under normal day-to-day circumstances, they run with a very mild respiratory acidosis, meaning that they will be pushed into a metabolic acidosis much quicker, resulting in vasodilation and fluid shifts much quicker than someone without COPD. As I said, there are far too many for me to point out here. I really urge you to think critically about different conditions and different medications that may preclude someone from starting in the compensation stage of shock, or may cause them to progress through the stages of shock more quickly than others. It's a great way to study. So we managed to get Elaine to a hospital before she deteriorates any further. And after we've handed her over, we noticed that the crew that transported Joseph were at the same hospital. We go over to them to discuss the case, and we find that they are less optimistic about Joseph's outcomes than we are about Elaine's. They report that Joseph deteriorated further, telling us that his obs on arrival at hospital were a heart rate of 55 with a new left bundle branch block pattern, a blood pressure of 60 on 35 despite fluid replacement therapy, a rest rate of 10 being ventilated with oxygen saturations diminishing despite high flow oxygen. We also find that Joseph is now completely unresponsive. This would be very sad news. This would mean that Joseph is now in irreversible shock. Let's go to the board and find out more. So what's the glaring difference between Joseph's obs from the moment we met him to the moment he arrived at hospital? I'd say the biggest change is in his heart rate, right? This trend from a tachycardia to a bradycardia carries huge significance in his shock progression. As the body progresses through decompensation, really the last line of defense is maintaining that rapid heart rate. Unfortunately, the heart, just like every other muscle, can only last so long when its supply of fuel begins to diminish. Now, through normal compensatory mechanisms, the absolutely vital organs, the heart and the brain, are prioritized in terms of blood flow. This means that they will be supplied for the longest period of time. Unfortunately, through the decompensation phase of shock, there's such a poor supply of oxygen and such a large buildup of carbon dioxide and lactic acid and all of these other really bad byproducts of anaerobic respiration that the supply of fuel to the heart no longer meets the increased demand of sustaining a tachycardia. This leads to global ischemia of the myocardium, and ischemia will progress to infarction being necrotic or dead tissue. An infarcted myocardium cannot contract with as much force as it used to. Add this to an ever-diminishing preload and we result in a huge reduction in stroke volume. If the conduction system of the heart becomes infarcted, we can end up with significant reductions in heart rate. If the SA node becomes damaged, we lose our ability to initiate a tachycardic response. If the AV node becomes damaged, its ability to pass signals between the atria and the ventricles becomes affected. This results in AV nodal blocks and significant reduction in heart rate. If either of the bundle branches are affected, we will start seeing those bundle branch block arrhythmias on our cardiac monitors. These will result in slower heart rates and also an inefficiency in ventricular contraction. Remember that heart rate at this stage is the last line of defense. So as soon as we compromise heart rate and reduce it, we are going to significantly reduce cardiac output, especially since we've also reduced a fair bit of contractility, which has further reduced our stroke volume. This huge drop in cardiac output combined with a massive reduction in peripheral vascular resistance from the decompensation phase means that we have huge crashes in blood pressure and huge reduction in perfusion. We see this trend with Joseph. His heart rate has dropped significantly from 140 beats per minute down to 55 beats per minute. This has caused his cardiac output to reduce so much that his blood pressure is now 60 systolic, down from 95. In all honesty, we would probably find it difficult to ascertain a blood pressure at all. So why is this irreversible? I can't understate just how insidious the shock process is. The initial stages of shock are brought about because we have a situation where we cannot supply our body's metabolic demand. But the way that the body responds to this is by increasing heart rate and increasing smooth muscle contraction. Those two actions will cause a net increase in metabolic demand. So by trying to improve our supply, we are increasing our demand. Now, this is all fine in those initial stages. We can maintain that for a while. But as we progress through the stages, that gap gets wider and wider and wider. And as that gap gets wider, we work harder and harder and harder, which widens the gap further. When we finally get to the irreversible stage, that gap is so wide that it becomes insurmountable. And our body's ability to respond is pretty much kaput. The consistent hypoperfusion of our organs has meant that all of my body's organs have remained in a hypoxic state for a long period of time, the entire period of time that we've progressed through these stages. Now, I'm not just talking about my heart and my brain here. I'm talking about my liver, my lungs, my kidneys, my GI tract, my bladder, my skin, and my skeletal muscle. All of these organs have been hypoxic for a long period of time. Hypoxia leads to ischemia, and ischemia leads to infarction. As all of these organs begin to infarct, they start to fail. And if all of these organs fail at the same time, we end up with a condition called multiple organ dysfunction syndrome, or MODS. This is a terrible condition and will most likely end up with significant morbidity or death. At the level of my lungs, the continued fluid shifts that I'm experiencing will cause fluid to shift from the intravascular space to the interstitial space, and from the interstitial space into my alveoli. Combine this with the fact that I'm starting to lose control of my diaphragm, and it pushes me into a condition called acute respiratory distress syndrome, or ARDS. To add to this, the continued acidosis and prolonged inflammatory state my body is in leads to a condition called disseminated intravascular coagulation, or DIC. To simplify this, it is a state where microthrombi or tiny blood clots form. These blood clots will go and get lodged in capillary beds throughout my body. As they become lodged in my organs, they worsen blood flow to those organs, adding to the acidosis, adding to the ischemia and infarction, and progressing MODS further. The prolonged hypoperfusion and acidosis will cause an altered conscious state and even coma. This can result in loss of airway control and respiratory depression. This is a patient who is pre-arrest and is unfortunately unlikely to survive. Okay, so how do we intervene? Well, in terms of pre-hospital management, the biggest and most important thing we can do is identify really early what stage of shock this patient is in and transport them without delay to the closest hospital that is appropriate to manage that patient. With shock, the only real definitive care is to remove the very stimulus that's causing the shock process in the first place. Whether that's through surgical intervention or prolonged medication regimens, we can't provide that service in the field. Now, that's not to say that we can't do other things. Our mandate in this whole operation is to transport that patient in as stable a condition as possible to the hospital. And there are some things that we can do to stabilize these patients. Now, the interventions that we provide vary greatly depending on the type of shock the patient is in and the stage of shock the patient is in. Now, to delve deeply into each of these interventions might make this video exceptionally long. So I'll touch on some of these interventions now, but I'll be covering each of the different types of shock in future videos, and I will delve more deeply into the various interventions in those videos. So watch this space. In general though, the main aims of management are to treat symptomatically. Ambulance interventions tend to range from fluid replacement, whether that's from crystalloid solutions such as sodium chloride or blood products, the administration of medications such as adrenaline and noradrenaline for their inotropic effects, that is their ability to increase cardiac contractility, and for their chronotropic effects, that is their ability to increase heart rate, but also for their vasoactive effects, the effects that cause constriction of blood vessels. All of this to try to promote an increase in stroke volume, increase in cardiac output, and an increase in blood pressure. Another thing we do is the provision of high flow oxygen. By giving high flow oxygen, we're maximizing the amount of oxygen that the hemoglobin is carrying, and hopefully we can counteract some of that ischemia and lactic acidosis. Now, as I mentioned, that is not an exhaustive list because there are other interventions out there that are specific to individual types of shock, but I won't cover them now. Okay guys, thanks so much for watching today. This has been video number 2. I'm pretty excited that it's out there. Please give this video a thumbs up if you liked it, and consider subscribing to the channel for more videos as they come up, and absolutely leave a comment down below and let me know if this video helped you out, if there's something you'd like to see covered, and if there's something I could do better. Thanks very much guys, and I'll see you next time.